Very good afternoon to everyone. We would like to welcome you all to the second edition of Masterclass by Dr. Rangarajan V. Before we start today's masterclass, let me just set some housekeeping rules, which all of us have to follow so that we can maintain the decorum of this session and can gain maximum out of it. This session is already being recorded, and a recorded version will be circulated back to all the attendees today through an email in a few days' time. If you have any question that you want to ask to Dr. Rangarajan, please feel free to post that question in the Q&A tab at the bottom of your screen. I would urge you to refrain using the chat tab here because that disrupts the flow of this presentation. So please share your questions only and only in the Q&A tab. We will have the Q&A session towards the end of this masterclass. So please keep posting it. Dr. Rangarajan will try to answer as many questions as he can. If some of your questions are not answered in today's masterclass, we will get back to you with the answers to those questions over an email in a few days' time. This session will be moderated by my colleague Ram, and he would be introducing the session to you as well as Dr. Rangarajan. Over to you, Ram.
Yeah. Thanks, Shruti. So Dr. Rangarajan, the speaker of the today's session, Dr. B. Rangarajan, he doesn't need much of an introduction because he is a renowned person in the prosthodontic space. Dr. Rangarajan is a prosthodontist and diplomate in oral implantology. He did his fellow in TMD, orofacial pain and obstructive sleep apnea and dental sleep medicine from Smile USA and Rosemont University. Dr. Rangarajan is also a dental advisor for Sri Venkateswara Dental College. He is a professor and head of prosthodontic department. He is a past president of Indian Dental Association, Madras branch. He was also past secretary cum treasurer and permanent EC member of Indian Prosthodontic Society. He is also the council member of Asian Academy of Prosthodontics. Professor B. Rangarajan has published many international and national journals. He also authored a book of textbook of prosthodontics along with Dr. Padmanabhan. That book is in the second edition. With this few words, I will hand over the session to Dr. Rangarajan to take us through the today's topic.
Thank you so much for the kind introduction, and a very, very good evening to everybody who's here. And at the outset, I want to welcome you all and thank you all for your time. And let us dive straight into the topic today. So I'm going to talk on principles and design of cast partial dentures. So when we talk of cast partial denture design, the correct design basically incorporates proper use and application of mechanical and biologic properties. So we need to understand here that not only biological principles are involved, but also mechanical principles are also involved. So let us go step by step how we can think of designing a given situation for a cast partial denture. As I said, mechanical principles are involved. So machines are classified as simple and complex. Complex machines are combinations of many simple machines. And when we look at simple machines, we know the 6 ones. This is the lever, the wedge, the screw, the wheel and axle, the pulley, and the inclined plane. So I'm sure all of us know this even at a school level, that these are the 6 simple machines. So what really, which one of these are we using in our cast partial dentures? The lever and the inclined plane. These are the 2 simple machines that are involved in the partial denture design. We have to understand that lever, this is a lever. A lever is any rigid bar that is supported somewhere along its length. And the support point of the lever is called as the fulcrum. So very simple to understand. And basically there are 3 orders of lever. The first is, of course, the prime example is a seesaw, where you have the fulcrum in the center, you have the effort on one side and the resistance on the other side. The second is, of course, the wheelbarrow, where you can see that the fulcrum is right at the end with the resistance in the center and the effort. Okay, this is the wheelbarrow. And the third is, of course, the fishing. So when you put the fish hook, the fulcrum is right at this side and the effort is now in the center and the resistance is at the other end. So this is how the various types of levers are divided. Now, how is this correlated to what we are doing in removable partial dentures? Most important thing for us to understand is the distal extension based removable partial denture. This is the most difficult thing to design because this is where maximum forces, all types of forces are are accruing on the RPD, and these are not completely supported by teeth because especially the class 1 and class 2 RPD, because distally there is no tooth, it's only the denture. So distal extension RPD acts as a class 1 lever. How does it act as a class 1 lever? For example, if you see here, the occlusal rest, okay, and this is your normal circumferential clasp, and that is where the tip of the circumferential clasp or the retentive tip is what goes into the undercut or below the height of contour. So that is the resistance. Your occlusal rest will be the fulcrum, and wherever the patient choose, is going to be the effort. So as the patient choose, what's going to happen? Your denture base is going to go down. When it goes down, what happens to the front here? That is the resistance. It tries to lift up. So the clasp will try to lift out of the denture. That's what will happen. This clasp will try to lift out of the denture. And every time the clasp tries to come out of the denture, it is going to give a lateral force on the abutment. So that is what we need to be careful about. So in a distal extension RPD, there exists potential for detrimental class 1 lever-like forces to accrue on the abutments depending on the design. This is the most efficient and easily controlled lever. Most efficient means it's more dangerous also. But the good thing is it can be easily controlled by our design, which we are going to see later. Now the class 2 lever is in the indirect retention principle, which I am going to explain later also. So we can see here the indirect retention. You can see this without this auxiliary rest here, which is going to be placed as far anteriorly possible. Now just imagine if the patient is going to bite and on a sticky food and the denture tries to lift up. This part is going to prevent this from lifting up. Now this is the effort. Now the resistance has come in the center and the fulcrum has gone to one end. So that is a class 2 lever principle, which we see in our indirect retainers. And you saw class 1 lever principle in our direct retainers in distal extension RPDs when there is no indirect retainer. So these two we need to understand and keep in mind. That is very, very important. Class 3, of course, does not, we don't have encounter class 3 in our RPD design. The next simple machine that we need to worry about is what is called as the inclined plane. So the inclined plane principle, we can see here one cube or one side sliding over the other. This principle is seen in the occlusal rest construction. When we go and construct an occlusal rest, we see the inclined plane principle. Now you can see here, and when you can also remember from your past what you have read about the occlusal rest. Most important thing about an occlusal rest is it should be at an angle, placed at an angle less than 90 degrees. Now, if you are going to place the occlusal rest at an angle of 90 degrees or greater, that is when you are going to have an inclined plane effect, and you are going to magnify the stress that is transmitted to the abutment tooth if the rests are not properly prepared. So we have the lever principle and we have the inclined plane principle when we are making occlusal rests. So we saw what are all the mechanical aspects of the RPD. Now let us look at what are the forces acting on the partial denture. As I said before, tooth supported RPD is rarely subjected to any rotational stress. But the distal extension partial denture is subjected to rotation around 3 principal fulcrum lines. What are these? Now you can have one rotation like this. Fulcrum on the horizontal plane. The fulcrum is passing through the distal extension 2 rest seats. Fulcrum is on the horizontal plane and the movement is on the sagittal plane. This results in rotation of the denture base away and towards the tissue. This type of movement is what we are talking about. This happens on the horizontal fulcrum line. Now it is difficult to control the movement around this fulcrum line. The magnitude of rotational movement is greatest around this fulcrum line, but not around this fulcrum. So it will keep moving up and down. The magnitude of rotational movement is greatest around this fulcrum, but not the most damaging, because these are vertical forces. So what happens here? We are not getting much horizontal forces here. These are more vertical forces. Vertical forces are generally tolerated better by the abutment teeth, as you all know, rather than your horizontal or off vertical forces. And also the fibers of the periodontal ligament are better equipped to resist vertical forces than horizontal forces. Even though this movement is difficult to control, but still it is not so dangerous as the other movements. What is the next type of movement? The next type of movement is in the sagittal fulcrum line. Now, this extends. What does this fulcrum do? This extends from the crest of the occlusal rest on the terminal abutment along the crest of the alveolar ridge on each side of the arch. So you'll have one fulcrum here and one fulcrum here. So this controls rotational movement, this kind of rotational movement. So this is rocking or side to side movement. This side of rotational movement is produced by this kind of a fulcrum line. Now movements are easier to control around this fulcrum line. They are of lesser magnitude, but most importantly, they are more damaging as the direction is horizontal rather than vertical. This is the second type of force that is acting on the RPD. Now, what is the third type of force? This is the vertical fulcrum. This moves. This is moving in this direction, the rotation. So this is located in the midline, lingual to the lower anterior teeth, or the same thing in the upper also. Controls movement in the horizontal plane, flat circular movements of the denture. As I said, flat circular. So you had one which was up and down movement. You had another which was side to side movement. And the third is a flat circular movement. So these are the three types of forces that are acting on the RPD and which we need to control with our design so that deleterious forces are not accrued onto the abutment teeth. So we saw the forces. Now let us see what are the factors that influence the magnitude of the forces that are being transmitted to the abutment teeth. The first thing is the length of the span. Obviously, the greater the length of the span, for example, from canine onwards, all the teeth are missing. The force on the canine will be much more than if there were only 6, 7, 8, first molar, second molar missing. So that is what we need to understand. The greater the length of span, the more force will be transmitted to the abutment teeth. So whenever, even before we are thinking of doing something to the patient, like giving a prosthesis, we want to try to retain as much as possible the posterior teeth so that the span length is less. Next is the ridge support, quality of support of the ridge, of the residual edentulous ridge. Now, large well-formed ridges are capable of absorbing greater amounts of stress. They also provide greater stability. Whereas a flat ridge, if it's just flat, okay, it provides good support, but it doesn't provide good stability. Now, a sharp spiny ridge or a knife edge ridge provides both poor support as well as poor to fair stability. And a soft, flabby, displaceable tissue provides both poor support and poor stability. So we need to understand here that as the quality of the ridge goes down, as it becomes more and more poor, the amount of force that is transmitted to the tooth is much more. And you cannot transfer any of the load to the ridge, like we can see later how we can do. So the type of mucoperiosteum, that is the gingival type, also influences the magnitude of stresses transmitted to abutment tooth. Healthy thick is better than atrophic. A healthy thick mucoperiosteum is better than an atrophic mucoperiosteum. More flexible the clasp. Next, coming to qualities of the clasp. More flexible the clasp, less stress is transmitted to the abutment tooth. But you have to understand very clearly here that more force will be transferred to the edentulous ridge. The selection of the clasp will depend on whether the abutment or the ridge needs protection. So very clearly understand. So whenever we are making a cast partial denture, everything is cast metal. It is nothing is flexible here. So if you want to make something flexible, then you have to introduce a wrought wire, just like our ortho wire, in the retentive arm. That is of course called as a combination clasp, which we'll see later. So we have to understand that more flexible the clasp, less stress is transmitted to abutment tooth, but more stress is transmitted to edentulous ridge. So we have to plan where to give more stress, whether on the tooth or to the ridge. Clasp design. Very important that the clasp should be designed such that it is passive on complete seating. And during insertion or removal of the prosthesis, the reciprocal arm, we have the reciprocal arm and the retentive arm. The reciprocal arm should contact, when we are placing the denture, the reciprocal arm should first contact the tooth and it should brace or stabilize the tooth. Then only the retentive arm should move in and go underneath the undercut, because when the retentive arm is going below the undercut or going past the height of contour, it will give a lateral force on the tooth. So if your reciprocal arm is already not bracing it, then that force is going to be very deleterious on the tooth and the tooth can start moving. So that's why it is called as a bracing arm or a reciprocal arm. So that when the denture moves out or in, the bracing arm has to contact the tooth first, then followed by the retentive arm. Length of the clasp. More flexible the clasp, I already told you that less stress will be transmitted on the abutment tooth. So what we can do, even in a cast partial denture or when everything is cast, now this is where the undercut is. This is the area that I'm going to involve with my clasp. Instead of making a straight clasp like this, where the length of the clasp is going to be not too much, I can make a slightly curved clasp and make the clasp more longer. The same undercut only I am engaging, but I am increasing the length of the clasp. So the flexibility of the clasp can improve and also the force on the abutment tooth will then be less. So clasp length, as I said, can be increased by using a curved rather than a straight course on the abutment tooth. Next, coming to the material used for clasp construction. Of course, here in our country, we are not using any precious alloys at all. Most of the time, we are using only base metal alloys. Chrome alloys being more rigid will exert greater stress on the abutment tooth as compared to gold alloys. Gold alloys are not so rigid. They have more ductility and malleability. Nickel chrome and carbon chromium alloys will exert more stress on the abutment tooth, but we really don't have a choice. So the clasp arm of chrome alloys are constructed with a smaller diameter than a gold clasp and will also engage smaller undercut. For example, see here, the same undercut. If it's a chrome alloy, I will engage only this much of the undercut and I will use a smaller diameter. I'm using a smaller diameter. Where if it's a gold alloy, I can engage a greater amount of undercut. Maybe here I'm using 0.01 inch. Here I'm using maybe much more, 0.02 or 0.03. And then here I'm going to make sure that this clasp is slightly thicker. So that is the difference when we are using chrome alloy or gold alloy. But here we don't have a choice. We have to use our cast chrome, cobalt, chromium alloys. Abutment tooth surface. Now also it depends on whether the surface of the gold crown or restoration, they will offer more friction resistance to clasp arm movement than does the enamel surface of the tooth. So the abutment tooth, if it is a crown, then the stress transmitted is going to be more. The abutment tooth, if it is a filling, again stress transmitted will be more. But abutment tooth, if it is completely enamel, then stress is going to be much less. So that is the meaning of abutment tooth surface. So we are seeing, first we saw what are the forces on the tooth. Now we are seeing what are the factors influencing the forces. And finally, occlusal harmony. Any deflective occlusal contacts are going to be really deleterious on the abutment tooth. We want smooth functioning occlusion. Also, we have to take into consideration the opposing dentition. Now, suppose you have a lower distal extension base, class 1 partial denture. There is going to be a lot of difference in force if the upper is completely dentulous or if the upper is a complete denture. So that also needs to be taken into consideration when we are designing the lower cast partial denture. And very important is where do you give the area of the load? The maximum area of the load should be ideally applied in the center of the denture bearing area. That is somewhere here. We should not give the load in the distal extension somewhere in the end here. It should be in the center of the denture bearing area, antero-posterior as well as mesio-distal and mesio-distal as well as buccolingually. So that is what we need to understand here. So don't go and place all your maximum contact somewhere in the distal end of the denture. We would prefer it more towards the center of this area, both antero-posteriorly as well as buccolingually. So we saw the forces, we saw the factors influencing the forces. Now what we must do? Every effort must be made to control or minimize these rotational forces through our RPD design. So how are we going to do that? So let us look at the design considerations for stress control and take each one of these components. So first is direct retention, and clasp retention should be kept at the minimum, yet provide adequate retention to prevent dislodgement of the denture. As I said, the retentive tip is the culprit. It transmits deleterious forces to the abutment as it goes in and out of the undercut. Other factors should be used to contribute for retention. So keep clasp retention to a minimum and get other factors in. So what are the other factors that we can take support of in a distal extension? Because we are covering the ridge, just like a complete denture, we can rely on adhesion and cohesion. So how can you get good adhesion and cohesion? The denture base must cover maximum area as possible, must be accurately adapted. That's why our impressions are very important. Atmospheric pressure, just like our posterior palatal seal in complete denture, in the maxillary complete palatal plate major connector, when we use a complete plate and we give a sort of a ditch or a nick in the end, that is going to the atmospheric pressure will then help only in the maxillary complete denture. How are we going to get frictional controls? By our guide planes. All of you know what are guide planes. On all the proximal surfaces of the adjacent to the edentulous area of the abutment tooth, you are going to make surface which are vertical and parallel to each other. So those are called as guide planes. So create nice guide planes and they will give you frictional control. And very important finally is neuromuscular control. All of you understand the same thing in a complete denture. The polished surface of the RPD, buccally in a lower, lingually, it should all be contoured such that the cheeks and the lips will come and give a nice stability to the denture, not concave, convex. It should be slightly concave, so that your cheek and on the outside and your tongue on the inside will come and give proper support and stability to the denture. The clasp position. Next, coming to the clasp position, is very important. The position of the retentive clasp is more important than number of. There's no point in mindlessly giving 100 clasps. We need to understand where to place them. So obviously the number of clasps is determined by the classification. For example, which is the best type of configuration? A quadrilateral configuration. This is a quadrilateral configuration. Now obviously this configuration is indicated only in class 3 arches, particularly when modification space exists on the opposite side. A retentive clasp is positioned on each abutment. So if suppose I always adjacent to the edentulous space, that tooth has to be clasped. We'll see later what type of clasp. So this is a class 3 situation, class 3 modification 1. All the teeth adjacent to the edentulous space will be clasped. So you will get a quadrilateral configuration. And this quadrilateral configuration is the best configuration and is the most stable configuration, and it will reduce stress maximum. That's why in class 3, we really don't have much of a problem. Suppose there is no modification, you have a class 3 like this, there is no modification at all. Even then what you will do to achieve this quadrilateral configuration, you will give one clasp anteriorly here and one clasp posteriorly here. Obviously, all of you understand that the type of clasp, circumferential clasp that we give in between teeth is the embrasure clasp. So you will give an embrasure clasp here and here and make a design again quadrilateral. so that we can get the best stable configuration. So in this design, when we give quadrilateral, the leverage is effectively neutralized. Next, tripod configuration. So best is quadrilateral. Next, coming to tripod. So this is primarily used for class 2 arches. Now, for example, now this is a class 2 with a modification 1. So obviously, which all teeth will be clasped? The one adjacent to the edentulous space here, adjacent to edentulous space here, adjacent to. So we are going to get a tripodal configuration, a triangular configuration. So when modification space exists, all the teeth adjacent to edentulous space are clasped, resulting in this configuration. It is not as effective as quadrilateral, but it is still effective in class 2. But we really don't have much of a choice. We have to go with this configuration only, which is a tripodal configuration in your class 2 distal extension base. Now, again, similar to the other class 3, if only pure class 2 is there with no modification, you will try to you will try to put one clasp on the dentulous side of the arch, one positioned as far posteriorly as possible, and the other positioned as far anteriorly as possible, such as intraocclusal space, retentive undercut, and aesthetic considerations will permit. So again, here also you will get a sort of a triangular configuration. So in class 2, you will get a triangular. In class 3, you will get a quadrilateral configuration. Bilateral configuration is usually used in class 1 arches. The terminal abutment tooth on each side of the arch must be clasped regardless of where it is positioned. So obviously, so this is the terminal abutment, this is bilateral. So in class 1, we don't have a choice. We have to give a bilateral configuration. Next, coming to the clasp design. So we saw the clasp position, the quadrilateral, tripod, and the bilateral. Now, what type of clasp we are going to give? Now, in a distal, all this is pertaining to distal extension base, because that is where maximum forces are coming. Conventional circumferential clasp originating from the distal. Now, suppose this is the normal clasp. You are having a distal extension base situation. You are giving an occlusal rest here on the distal side, on the distal part of the tooth. And it is engaging what undercut? This is the mesiobuccal undercut. This is your normal circumferential clasp. But what happens here in this normal circumferential clasp? Every time the patient bites down, what's going to happen to the clasp? The clasp is going to try to lift out of the undercut. Every time it tries to lift out of the undercut, it's going to give a force on the abutment tooth. So a cast circumferential clasp, the normal simple circlet clasp, should never be given in a distal extension base situation. So what are the alternatives for this? What do we give? We need to give a reverse circlet clasp. So what the reverse circlet clasp does, it comes from this side instead of here. You know what is a reverse circlet clasp? Takes there is an occlusal rest on the mesio-occlusal surface, and then it engages the distobuccal undercut. Now the same thing you see here. Now when the patient bites, what is going to happen to this? This is going to sink into the undercut further. It will not try to come out of the undercut. So as the denture moves down, the clasp moves further gingivally into the undercut without contacting the abutment. That's why this is a good alternative. But for that, you need an undercut on the distobuccal surface, okay, on the distobuccal surface of the tooth. So that is the reverse circular clasp. I said that you are going to keep engage a mesial occlusal rest rather than this is the mesial occlusal rest. So, but the problem is the clasp may produce wedging force between the abutment and the other tooth, which can be countered by placing another distal occlusal rest, okay, on the adjacent tooth also. Then we come to the vertical projection or the bar clasp. This is used, okay, this is another alternative. This is again used in distal extension partial denture when retentive undercut is located on the distobuccal side. Again, retentive undercut has to be located on the distobuccal side, So never when the tooth has a mesiobuccal, you will never give a vertical projection of bar clasp, because then that function will be similar to your simple circle clasp. It will start hitting the abutment tooth. Now when it engages the distobuccal undercut, when it engages this undercut and the patient bites down here, this part, the clasp, the retentive tip is going to go down rather than come out. That's why we can give a vertical projection or bar clasp or a reverse circular clasp to engage the distobuccal undercut in a distal extension based situation. Okay. Some clinician feels use a mesial rest, okay, instead of a distal rest for the bar clasp, they use a mesial rest, as they feel moving the fulcrum anteriorly will direct forces more vertically. But the problem is you could have a lot of foot impaction here. So there are two schools of thought on how to use a bar clasp. You could use a mesial rest or you could use a distal rest. Okay, now this is if your undercut is present distobuccally. Now what if the undercut is present mesiobuccally? You cannot give your simple circular clasp. So we don't have a choice. What are we going to do here? Now we give what is called as a combination clasp. In a combination clasp, what happens? It is used when the distobuccal undercut exists on an abutment tooth. Sorry, a mesiobuccal undercut exists on an abutment tooth, not distobuccal. Wrought wire. So because there is going to be force transmitted, I told before a wrought wire retainer is more flexible than cast wire. So you will give a combination clasp where only the retentive terminal, only the retentive tip, this part alone is made of wrought wire or the orthodontic wire that we use. The rest is all cast. That is cast as a combination clasp. Here we don't have a choice. So we make more flexible so that less stress will be transmitted on the abutment tooth. Next, coming to the other design considerations, splinting, fixed and removable splinting. So fixed splinting using crowns. When will I do fixed splinting using crowns? When there is loss of periodontal attachment by disease or therapy. When the abutment has tapered or short roots. When the terminal abutment stands alone. For example, see here. Now this is missing. This lateral incisor is missing. Distal extension is also missing. What we can do here? We can make a fixed partial denture coming from central to canine, a 3-unit bridge, and then the posterior alone can be a removable partial or a cast partial denture. So we are splinting this because this is standing alone. It doesn't have any support in the anterior as well as posterior. We splint this to the adjacent tooth and then give a cast partial denture. But we should be careful here. An extremely weak tooth should not be splinted with a strong tooth. That has to be very, very clearly understood. That is fixed splinting. What about removable splinting? So should not be done. So removable splinting we generally don't do. It should not be done if fixed splinting is possible. More than one tooth is clasped on each side of the arch using a number of rests. So here you have to give more clasp and more rests on other teeth. But most of the clasp will not be retentive. You don't want it to keep moving up and down of the undercut. And the main advantage of removable splinting is not only the components on this side, you transfer it to the other side. So cross arch splinting is it takes advantage of cross arch splinting. Next, coming to an important concept called indirect retainer. What is this indirect retainer? I told you before, in a distal extension based situation, this is the problem. You're having effort here, fulcrum in the center and the resistance here. You bite down, this clasp is going to keep trying to come off the undercut, going to create stress on the abutment. So what are we doing now? If you see here, we are going to give one more occlusal rest anterior to this. So what are we doing? We are shifting the fulcrum from here more anteriorly over here, so that when this denture tries to lift up, this is going to go down and it will prevent the denture from lifting up. See here. So if we try to lift up the denture, this is the indirect retainer. This will go and hit the tooth. It will not allow the denture to lift up. So now you see the definition. It is that component of the removable partial denture that assists the direct retainer in preventing displacement of the distal extension base. So it basically prevents displacement. It helps in retention by functioning through lever action. On the opposite side. From here, this is the opposite side. This is here. It goes to the opposite side of the fulcrum line. When the denture base moves away from the tissues in pure rotation around the fulcrum line. Now you will be able to understand the definition of indirect retainer. In a class 1 situation, indirect retainer is mandatory. For example, your occlusal rest is here, your occlusal rest is here, your clasp is here. You will give one more occlusal rest, additional rest. You can see here one more additional rest anteriorly. So there will be 2 indirect retainers on either side bilaterally. Try to place it as far anteriorly as possible. Class 2 is not critical. Now see, in a pure class 2, what are we going to do? I told you we are going to go in for a tripodal configuration. So anyway, what you will do, you will place an occlusal rest as far posteriorly here. You will place an occlusal rest as far anteriorly here. You will get a tripodal configuration. And this occlusal rest will automatically act as an indirect retainer. So you don't have to give a separate indirect retainer in a class 2. Now, if a modification space exists, nothing to worry at all. Automatically, this is going to act as indirect retainer. This clasp will act as indirect retainer. Nothing to worry at all. Now, okay, the modification space exists here, but it is not present very much anteriorly. Only then what you will do, you will give another indirect retainer, probably as far anteriorly as possible. That will serve another occlusal rest as an indirect retainer. In a class 3, of course, no indirect retainer is necessary. Is not necessary as there are no rotational forces. Class 4, reverse. Again, we are going in for quadrilateral design. So you will now give an indirect retainer placed as far posteriorly as possible rather than as far anteriorly as possible. Just the opposite of class 1. So the indirect retainer will be placed as far posteriorly as possible. Now, how about the occlusion? Occlusion has to be in harmony with movements of the TMJ and musculature, and this will only minimize the stress transferred to the abutment teeth and the residual ridge. Occlusion, the initial occlusal contact should always be in the remaining natural tooth, meaning you have put the denture in the mouth. Now, when the patient closes, the first contact has to be in the natural teeth. Your denture or the artificial teeth should never contact first. The mandible should not be guided into protrusive or lateral movements by the metal or artificial teeth. Again, only your natural teeth should guide protrusion and lateral movement. Reproducing the buccolingual width and the number, reducing the buccolingual width and number of the replaced teeth reduces the stress transmit, just like your complete denture. And contact of the natural teeth should be the same, whether denture is in mouth or not. So you remove the denture, ask the patient to close and see and tell figure out the contacts, put the denture back in place. The same natural teeth only should contact. You should not have more contact on your artificial teeth. Again, sharp cutting surfaces and sluice ways can help relieve some unnecessary force during mastication. Steep cuspal inclines on artificial teeth should be avoided because they tend to introduce horizontal forces detrimental to the abutment. So that is occlusion. Denture base, I told you before about neuromuscular support or stability. Should can cover maximum area as possible. Flanges should be as long as possible. Overlooked extension should be avoided. In the lower, it should cover the retromolar pad. In the upper, it should cover the tuberosity. All this is mainly for your distal extension based situations. The contour of the polished surfaces should be good, as I said before, and accurate adaptation of the denture base also lessens movement of the and reduces stress. Major connectors, some major connectors can again help with your distal extension based situation. One such type is your lingual plate. You can see much more stability here with your lingual plate. So in the mandibular arch, the lingual plate major connector properly supported by rest aids in distribution of the functional stress. It also supports periodontally weakened anterior teeth and helps in cross arch stabilization. Whereas in the maxillary arch, your complete palate or your broad palatal major connector will distribute stress over a large area and contribute to support and stability and retention of the prosthesis. So when you are doing distal extension based situations, you should think of a lingual plate or a complete palatal coverage in your maxilla and mandible. Minor connector, just like all others, most important thing is your guide planes. These are your guide planes, okay, on the proximal side of the abutment teeth. Intimate contact to partial denture is brought by the contact of minor connectors, that is the guide planes. It offers horizontal stability to partial denture against lateral forces. Then the rests are also very important. They control stresses. We told before, make it slightly at an angle. Don't make it too much at 90 degrees or obtuse angle. Periodontal ligament is better suited to withstand vertical rather than horizontal force. Must be at an angle less than 90 degrees. The rest seat should be saucer shaped. In a distal extension based situation, it should be saucer shaped, so that, because in a distal extension base always there is movement of the denture. That's why we need to be so careful, so that some movement of the denture is allowed, so that forces are not transmitted to abutment. So these are all how with our design we try to control the stresses. This I want all of you to go through. These are just a set of principles that are developed by Schmidt in 1956. So thorough understanding as before, whatever we spoke before, all that has to be mentioned here, the biomechanical and biologic factors. And then treatment plan must be based on a complete examination and diagnosis, must correlate pertinent factors and then develop a treatment plan. The prosthesis should restore form and function, and a removable prosthesis is a form of treatment and not a cure. So these principles of design took into consideration whatever we have told so far. Now the philosophies of design, coming to the philosophies of design. Of the various schools of thought, none are backed by scientific research or statistics. Nobody can say that my design is better than other. Everything is, they are all ideas of dentists who by extensive clinical experience have formulated rules by which they produce a design. That's all. If the physiologic limits of the supporting tissues are respected, then almost any design can be successful. The challenge, as I've kept harping on it, the challenge in design lies primarily in class 1 and class 2 arches, and to some extent in the class 4 arches, and distributing the forces acting on the removable partial denture between the soft tissue and the teeth. So that is the challenge, whether you want to give more force on the abutment tooth or transfer the stress to the ridge. That is the challenge when we are looking at philosophy of design. So basically there are three philosophies of design. One is the stress equalization concept, second is the physiologic basing, and the third is the broad stress distribution. So what is this stress equalization concept? So here, this concept states that the resiliency of the tooth secured by the periodontal ligament in an apical direction is not comparable to the greater resiliency and displaceability of the mucosa covering the edentulous ridge. So what does it mean? Therefore, it is believed that if you are going to have a type of stress equalizer, so what you can do is you can reduce then the stress on the abutment tooth and transfer it to the ridge. So these stress breakers are also called as articulated prosthesis, and there are basically two types. So basically you are trying to reduce the stress on the abutment and you are shifting it to the residual ridge. How are you doing that? Stress equalizer having a movable joint between the direct retainer and denture base. For example, if suppose this whole thing were not attached and it was not joined together, this part alone is movable because of some kind of a hinge joint here. So what happens whenever the patient bites or chews, this will move up and down. Nothing, this part will never move. So there is no transfer of the stress to the abutment tooth at all. That is the one concept, stress equalizer concept. So they may be hinges. You can use a hinge, you can use a sleeve, cylinder, ball and socket joint. You can use anything here. So what happens is they allow vertical movement and hinge action of the distal extensor denture base and help transfer load from the abutment tooth to ridge. So these are all examples, commercial examples of these type of attachments. The second is having a flexible connection between the direct retainer. One was a movable joint. Second is a flexible connection. Now see here, this major connector, this lingual bar major connector is split into two or just divided here. Though it's not divided along, it's not like made into two. Part of it is divided. So when the patient bites down, only this part is going to move. This part alone moves. This part is not moving. So the stress transfer to the abutment tooth is completely missed. So you are transferring stress from the abutment tooth to the residual. So what are the advantages of the stress equalization concept? Obviously, minimum direct retention is required, as because the clasp doesn't keep bobbing up and down. So that is a advantage. Minimize tipping forces on abutments, thus preserving its alveolar bone support. So you are not going to have much force on the abutment tooth. propose that the force is now evenly distributed. They propose or think that it is evenly distributed between the abutment and the ridge. And this intermittent movement of the denture against the mucosa, the proponents of this theory felt that they has a massaging or stimulating effect on the soft tissues. And splinting of weak teeth is also possible, they propose, because there is not going to be any force on the abutment tooth. And if relining is not done when needed, the abutment will not be damaged, but there will be some other problem. What are the disadvantages? Obviously, all these attachments and other things are complex in construction, and they are also costly. Constant maintenance is required as it's difficult or impossible to repair. Vertical and horizontal forces are concentrated now on the ridge. So you're going to have rapid resorption of the ridges. If relining is needed but not done, excessive ridge resorption will happen. Effectiveness of indirect retainer is completely lost because this is moving indirect on its own. So there is no point in giving an indirect retainer, but more foot entrapment in the joint and spaces is going to happen because there's going to be a movable joint, and it can easily distort if it is not handled properly. So that was all the stress equalization concept. Now coming to the physiologic basing concept. This school of thought too believes that there is lack of movement in the abutment, relative lack of movement in the abutment teeth in an apical direction. But it believes that stress equalization can be how you can achieve it, not by how we said before, by displacing, giving pressure on the mucosa during impression making procedure. So, or by relining the denture later by giving some pressure. So you could do this. That is what the proponents of this theory said. They wanted us to make an impression or a mucocompressive impression by giving pressure on the ridge while making an impression. So what happens here? The tissue surface is recorded in a functional or when the patient is biting hard and not in the anatomic form. Prosthesis constructed from tissue displacing impression will be what happened? When the patient bites, the denture will go and fit nicely. But when the patient goes to vertical dimension at rest, the denture will lift up. It won't go and seat on the residual ridge. So to permit vertical movement from the rest position to functional move position, because this will keep happening. So your retentive clasps have to be minimum retention, and also their number has to be less. So clasp retention has to be minimal in this philosophy. So here what do we do? This is the anatomic position of the mucosa. Let us say it is like this much of the mucosa. Now what we do, we reduce the thickness of the mucosa by making a mucocompressive impression. Now what's going to happen here? When the patient bites, the denture will fit nicely. But the patient is not chewing, the denture will lift up. Because it is not fitting, it's not going to fit on the mucosa. That is basically the concept. And it will go and rest above the occlusal plane. So every time the patient goes and bites, what is going to touch first? Your denture teeth is going to touch first, and then it will be pressed into occlusion. So advantage, okay, the proponents of this theory said intermittent base movement has a physiologic stimulating effect on the underlying bone and soft tissue, less need for relining and rebasing, simplicity of design, looseness of the clasp reduces the functional forces on the transmitted to the tooth. That was their main, reason for this philosophy. But there are a lot of other disadvantages. The denture is not well stabilized against lateral forces because your clasp itself is not seating. How will your reciprocal arms seat them? There will be always premature contact when the mouth is closed, which is uncomfortable to the patient. It is difficult to produce effective indirect retention because it's keeping bobbing up and down. So that was philosophy number 2. The third philosophy is broad stress distribution. Distributing the forces of occlusion over as many teeth and as much of available soft tissue as possible. This is what we all are doing and using, and this is what is propagated in most of the books. Achieved by means of additional rests, indirect retainers, clasps, and broad coverage denture bases. Advantages, all are good. Teeth can be splinted, prostheses are easier and less expensive to construct. No flexible or moving part. Indirect retainers and other rigid components provide excellent horizontal stabilization also apart from retention. Less relining is required. There are disadvantages, greater bulk because you will be having additional rest. to be less comfortable, increased amount of tooth coverage because many teeth need to be clasped and rests need to be placed, so that can lead to caries. Out of these three philosophies, stress equalization and the other philosophical physiologic basin also have few advocates. Broad stress distribution is the most widely used philosophy and will be followed in our design procedure. So now we saw what are the forces acting on the tooth, what are the factors controlling these forces, how we can control these factors by the components, what are the philosophies and design, what philosophy we are going to use, and now we will go to the essentials of the design. Just to summarize the whole thing, now you can easily design a partial denture. When we look at the essentials of design, obviously what is most difficult to design is the class 1 and class 2, and they will be considered together as their principles are similar. So in class 1 and class 2, as we already said before, direct retention, clasp retention should not be considered the prime objective of design. You don't need to make your clasp very, very tight. Most important is get more support from the ridge by proper contour of an adequately extended denture face, accurate fit of the framework against multiple properly prepared guide planes, and they should be used to help the retentive clasp arm retain the prosthesis. So not only clasp, get retention from the other factors that we already saw: adhesion, cohesion, atmospheric pressure, and other things. So clasp, in class 1, use the simplest type of clasp. Class 1 prosthesis usually requires only, as we saw before, two retentive clasp on either side adjacent to the edentulous space, one on each abutment terminal. So we know what type of clasp. If you are going to engage the distobuccal, if the undercut is in the distobuccal area, you will use a reverse circlet clasp or you will use a bar clasp. If the undercut is in the mesiobuccal surface, your only choice is to use a combination clasp. A simple circlet clasp or a prototype cast circumferential clasp engaging a mesiobuccal undercut is contraindicated in a distal extension based situation. A class 2 should have 3 retentive clasps. We all know that very well, 3 retentive clasps. Even if there is no modification space, I told you we are going to give one as far anteriorly as far posteriorly. So located on the distal extension side, the clasp located on the distal extension side, it is the same as class 1. Same, whether if it's mesiobuccal, give combination. If it is distobuccal, give bar clasp or give reverse circlet clasp. Whereas on this side, you can give because this is only tooth supported. This you can give your normal cast circumferential clasp. Here also you can give whatever circumferential clasp you want. Only on the distal extension base side, you need to make sure what type of clasp you are giving. And of course, if there is no modification space at all, the only clasp you can give in between teeth, both anteriorly and posteriorly, is your embrasure clasp. Teeth selected for rest preparation should provide maximum support possible, as we already saw. Rest should be placed next to the edentulous space. So most of the times we will be placing rest in the distal area. So with few exceptions. Next, coming to indirect retainer, as I said, class 1 and class 2 very important. You are going to give an indirect retainer in class 1, 2 indirect retainers on either side, both as far anteriorly as possible. This is just an occlusal rest with a minor connector, occlusal rest with a minor connector. Again, in a class 2, in a pure class 2, you are going to engage as far anterior and as far posterior possible. This occlusal rest here with its minor connector will act as the indirect retainer. So you don't have to worry about giving a separate indirect retainer. The major connector. The major connector, obviously, all the requirements that are specifically required, we talked before. Your lingual plate, as well as you could use a lingual plate in the lower or even a double lingual bar, and you could also use a broad palatal coverage in the maxilla. Minor connector must fulfill all the criteria and requirements for any minor connector, which you can go through in the book very clearly. Again, occlusion, most importantly, if there are sufficient centric stops, then MIP is utilized. What is MIP? Maximum intercuspal position. If there are insufficient centric stops, then centric occlusion is given. For example, now you are having teeth till premolar okay, and you are only replacing your 6 and 7, the first molar and second molar bilaterally on either side. Now there are sufficient centric stops in this situation. So you just you just ask the patient to bite. Patient will go into maximum intercuspal position with the existing premolars. So give your cast partial denture in that position. So you are basically giving a MIP position. Now if there are insufficient centric stops, for example, let us say right from premolar onwards all the posterior teeth are missing. You have only till canine. Now here you need to record your centric relation. You need to record your centric relation. Just like how we talked that day about complete dentures, we record the centric relation and give centric occlusion in this centric relation position. So that is the occlusion you will give for your class 1 and class 2. Class 2, of course, there is no problem. You are going to have sufficient contacts on the other side. So you can give in MIP. So if this situation will arise most often only in class 1 situation, where you could have lot of missing teeth in the posterior. If you don't have enough posterior contacts, then you need to record centric relation and give centric occlusion or give MIP in centric relation, which is called as centric occlusion. So that's what you need to do with occlusion. Denture base, as I said, a selective pressure impression, just like your complete denture. You could use your altered cast technique also. Should record the residual ridge in a functional form. So we don't want to compress it too much. As it is, what is there, what is required for function. Note the stress bearing areas and the other relief areas and other things, and then we should record it. Use a selective pressure impression. Class 3. So we saw class 1 and class 2, what all is critical in our design. Class 3, direct retention. Retention can be achieved with much less harmful. There's no problem at all. You're always going to get a quadrilateral configuration. The position of the retentive undercut is not critical. It doesn't matter. You can easily engage the distobuccal, mesobuccal. It doesn't matter. The clasps. The quadrilateral positioning of the clasp, as I told you, this is the quadrilateral positioning of the clasp is ideal. Tooth and tissue contours and aesthetics should be considered, and the simplest clasp possible should be selected. And rest seat should be prepared next to the edentulous space. Always we see here, rest seats are prepared next to the edentulous space, next to the edentulous space. Most often that's what we will do, except when we need to use something like a, as I said, like a reverse circlet clasp or something like that. Rest seat should be prepared next to the edentulous space when possible and fulfill all requirements. Indirect retention is not required for a class 3 because it is completely tooth supported. And major and minor connector, as always, must meet the requirements as per the indication. Occlusion, here enough posterior teeth will be there. So given in MIP has nothing to do with centric relation here. You don't need to record centric relation. Just ask the patient if there are sufficient teeth contact. You don't even have to record a bite. You can hand articulate and make the denture in that position. Denture base, a functional type of impression is not at all required here because the residual ridge is not going to provide that much of stability and support. Class 4, as I said, typically opposite of class 1 and class 2. Just picture this. So design is unique, the aesthetic arrangement, because here aesthetics is what is going to matter. You are not going to place the teeth on the crest of the ridge. So aesthetic arrangement of the anterior replacement teeth may necessitate their placement anterior to crest of the residual ridge, resulting in potential leverages. So planning should begin even before extraction. So you need to preserve the alveolar process, retaining teeth to serve as an intermediate abutment for an overdenture. All this has to be thought of before, and shorter edentulous span. All this will reduce the tilting leverages on your abutment teeth. So in a class 4, we saw quadrilateral configuration with the anterior clasp as placed as far anterior and the posterior clasp placed as far posterior. Always the anterior clasp means the tooth adjacent to edentulous space will be clasped and posteriorly as far posteriorly as possible. The major connector should be rigid and broad palatal coverage should be used in the maxillary arch. Indirect retention again should be not placed as far anteriorly as possible. Here should be placed as far posteriorly as possible. An ideal quadrilateral configuration is there, so you don't need any additional indirect retainer. That itself will take care of it. A functional type of impression may be indicated if the edentulous area is extensive. Only if you have a large anterior edentulous space, only then you need a functional type of impression. So this is what basically I wanted to cover. We were able to, go through all the various types of forces that are acting on the partial denture, the factors affecting these forces. Then we went to how we can control these forces by our components. And then we saw the philosophies of design. And then finally we saw how to design using these philosophies. So thank you so much for all the patient hearing, and I really appreciate Elsevier also for bringing this to so many students across the country. Thank you. And if there are any questions, we'll be happy to take the questions.
Thank you, Doctor. Thanks for your taking us through this particular topic. It was a very interesting session. We have a lot of questions, so I have highlighted few questions. We will try to answer them live. The first question is, are there any complication in RPD in COVID-19 patients? Something relevant to the current situation.
Actually, the research on COVID-19, we have not even come to research on COVID-19 and its prosthesis and its effect. Still, more oral manifestations of COVID-19 are still, very, we have still not been able to get any concrete data about oral manifestations. I mean, if somebody is asking about protection, obviously we need to be protected whenever we are treating a COVID-19 patient. Whatever, even if they are asymptomatic, you need to wear your N95s, your face shield, and your head cap, the PPEs, and then go and work on a COVID-19 patient. Otherwise, as far as the teeth and the mucosa and all are concerned, I don't think there is still any research yet which says that something is going to be affected there.
Oh, thank you, Doctor. Thanks for clarifying. So how to check the passivity of the clasp? That's the second question from Yashikar.
The most important thing here we need to understand is only the retentive tip, only the only component that is active in a partial denture framework is the retentive tip, not even the retentive arm. Only the tip has to go below, go in and out of the undercut. The rest of the area should never go. So when you are placing the removable partial denture, cast partial denture in and taking it out, we have to get a feel that it goes in, and finally only the retentive tip passes through the undercut. No other component should go and create any force. We will be able to clearly see, and that's why we are doing all this surveying and various other things before we even make the the cast partial denture. So we are blocking out undercuts. We are making sure that only the tip is exposed. So we need to make sure that only the tip goes in and out. The rest of them can contact, but it should be a passive contact. It should not give any active force. It should just go in nicely and come out, with the retention being obtained only in the end, provided only in the end. Right when you are pushing the RPD in, if you are going to need to have a lot of force to push it in, then obviously, your every component, that means every component or your guide planes, everything is giving an active force. So the whole partial denture should go in almost 95%, and only in the end you should feel the active component working. That's how you probably have to check whether the rest of the things are passive or not. Of course, our survey is there. Survey, we use the surveyor and various other things to check and make sure that no active forces, the rest of the components are going to be passive and parallel to the path of placement and removal. That's very important.
Thanks, Doctor. So there are other questions from Dr. Kopila Srija. How can we know where to give clasp in case of class 2 without modification for the tooth other than the abutment tooth?
I didn't get it. Can you repeat it?
Yeah. How can we know where to give a clasp in case of class 2 without modification for the tooth other than the abutment tooth?
Yeah, as I said, you are going to give one clasp anterior and one clasp posterior. So it's not that, we want to see, again, the surveying and the treatment planning comes in place. You need to look at where you can give a clasp without too much of wedging force between the teeth. So obviously, this is not rocket science. You are going to give the posterior last two teeth on the other side of the arch. There you are going to give one embrasure clasp. You are going to come to the anterior side. Anterior side means you are left with only canine and the 2 premolars. So you could use the 2 premolars, or you could use the 3 and the 4. So we just need to look at which is going to give us probably more retention with less sort of influence on the abutment tooth. This is going to be detected by our surveying and various other things. And then look at placement of the clasp as far posteriorly on that side and as far anteriorly on the same side.
Thank you, Doctor. So another question from Sanika Gokale. So do we need to use an indirect retainer when using a reverse circlet clasp in distal extension?
Yes, definitely. You should give a, you will need a, any distal extension based situation, you will need an indirect retainer. Whether you are using reverse circlet clasp or whether you are using a bar clasp, you will need a reverse indirect retainer is mandatory in class 1.
So another question from the more of a clinical practice point of question. Aneri Patel, as you said, in fixed splinting, big tooth shall not be included. So in the case which you showed, if either canine or incisor is weak, then what about replacing lateral? Clinically, it becomes dilemma when such cases are encountered. The teeth is not weak to be extracted, neither strong to give cinculum rest in case of distal extension or posterior to it.
Yeah, that's why I said then in those cases, rarely you will go for removable splinting rather than fixed splinting. You will try to give additional rest on those teeth. Okay, from the lingual surface, you will try to give additional rest so that those teeth are not affected. And you will try to, when you're going to go to the other side, this is probably, I think it was a class 2. We need to, when we take it to the other side, we may need to give additional components, additional rest, which will make sure that the stress is distributed. There is broad stress distribution. So we may not look at a fixed splinting here. We may have to look at removable splinting here.
Thank you, Doctor. So another question from Maya Sonigra. The class 3 lever is existing in RPD.
Class 3 lever is not existing in RPD.
Great, Doctor. Another question from Dr. Preeti Krishnamurthy. The occlusal scheme followed in 1, the mandibular or maxillary, distal extension opposing natural detention. And the second, upper and lower distal extension.
I didn't get it. Can you repeat it?
Okay. So the occlusal scheme followed in, there is 2 points she has mentioned. One is the mandibular or maxillary distal extension opposing natural dentition. Second, right. Upper and lower distal extension.
As I said, the occlusal scheme is, I don't know whether they are asking about the concept. The occlusal scheme is always dictated by the remaining natural teeth. So whatever, type of occlusion that exists on the remaining natural tooth, suppose there are sufficient, contacts. So if you are going to have sufficient posterior contacts, so you could, if the patient is having a canine guided occlusion, go ahead and give the same canine guided occlusion. If the patient is having a group function, go ahead and give the group function. Only if there are insufficient posterior teeth. Now, for example, many posterior teeth are missing, then you may have to look at, centric relation and balanced occlusion and other things. But even here, balanced occlusion may not be necessary. You could go ahead and give a mutually protected occlusion scheme.
Thank you, Doctor. The question from Dr. Harshad Mahan. What will be suitable design for maxillary and mandibular class 1 edentulous cases? As you said, the natural dentition should be in contact with the denture teeth.
I think I've already answered that. The occlusal scheme will be dictated by the natural tooth. Whatever is present there, give the same thing.
Yeah. Doctor, I think that's about the questions which we have for the important question what we have chosen for today. There are around 80 plus questions which are available, which are asked by the participants. We will kind of share it to you. You can kind of select and answer them, and we can send them over to email. So many people are asking about the digital certificate and the recorded session. As we rightly said, in a week's time, we would be sending the recorded session for all the participants who are registered in our session. They will get an email with a link and the digital certificate in a week's time. If they have any challenge, they can they can share their queries to indiacontact@lgva.com or the respective regional managers. So thanks once again for all the attendees for patiently attending both the session, and really appreciate. And thanks, doctor, for making your time available in your busy schedule. And
thank you so much, and I wish
session.
all of them the very, very best in their exams as well as in the future. Thank you so much.
I think have a nice weekend. Thank you.